Yes. Okay.
Okay. Now we'll go to the next slide, and I will take that. Is it visible now?
Yeah.
In your
Yeah, it's
computer?
now.
Yes.
Number 2.
Yes.
The
Number
second
2.
slide.
Now that is not in the slideshow.
That's okay. If it is moving.
This will be moving? Is it visible?
This is enough. This is enough.
This
Enough,
is enough. That's fine.
Yeah.
Yes, sir. Visible, sir.
This
Visible.
is enough to all the students. It's very visible. Okay, fine. So data need. So basically, hemodynamics. We have the pressures, flows, and resistance. Okay. Now, for this, the data needed is oxygen consumption. Oxygen consumption is the amount of oxygen consumed by the body in 1 full minute, or in liters. Then the oxygen carrying capacity, because oxygen is carried by the hemoglobin as well as dissolved oxygen in the plasma, which will be determined by the partial pressure of oxygen. Then these two things are needed. Then you should have the pressure tracing, but always correlate with clinical ECG, X-ray, and echo data. Okay. Now the next slide, how to approach the oximetry. You need the oximetry and pressure tracing. Is it visible in full screen?
It is visible.
Yeah.
It is visible.
Check aortic and pulmonary saturation. Slightly different. My approach is slightly different. We always talk about step up, step down, all those things. But I stress on check the aortic and pulmonary saturation, because it gives a lot of information. And look for the arteriovenous oxygen difference. It gives us a basic ideas about certain physiology. But usually we talk about the step up and step down. That is the next simple thing. Step up, step down at what level? Pressures, look at each pressure systematically. That is, you have to look at the pressure waveform, what is the contour, what is the peak pressure, diastolic pressure, all those things, depending on the chamber. Assess whether the values are normal or abnormal, and compare the pressure with all adjacent chambers and vessels. For example, a right ventricle has to be compared with right atrium, left ventricle, maybe pulmonary artery, and maybe even with aorta. So all these things have to be done. Is it visible now? Has it moved? No. Okay. Now the pressure tracing. Assess the basic rhythm. That's very important. Analyze the tracing to see whether it is atrial, ventricular, or arterial. That is the second step. Then the waveforms should be studied, its shape should be studied, values have to be considered, and compare, as I have told you. And this is one of the important things. Whenever you get the ECG, these people do not look into the ECGs or any timer or systole and diastole. Very, very important. People jump into analysis of the waveforms and the pressures. You have to mark out systole. There is one cardiac cycle from the peak of QRS or a little after the peak of the QRS to that is systole. And you have to sort out, there is a cardiac cycle. And from the QRS to a little after the end of the T wave, that will be the systole. And end of T to the Q is the diastole. So here you find that in a single cardiac cycle, there are multiple waves. That is atrial or venous. And after the onset of systole, you have the C wave, followed by the X descent, and the T wave corresponds to the V wave. You can say that the T wave corresponds to the V wave, and from the end of the T wave, the Y descent. And the P wave will be followed by, it will be followed by the A wave. Now, usually ask a question. There is ACV. How many waves are there in the venous column? Usually say there are 3 waves. X and Y are not waves. These are the descents of a wave. A wave has an ascending and a descending limb. Now I ask the question, what happens in atrial fibrillation? There will be only one wave. That is the answer, no. You take away this A wave. You have the C wave, X descent, V wave, and the Y descent. So you have the X prime, which is there, the Y is there. If there are 2 descent, there will be 2 waves. So it will be the C wave and the V wave. Usual answer is single wave. That is about the venous column. The arterial column, you talk about the ventricle. The ventricle pressure rises in systole, comes down, and you take diastole. We have marked the diastole from here to here. In diastolic, the pressure rises. That is the important thing. It's a high pressure system, and in diastole, the pressure rises. Whereas in an artery, you find that in diastole, the pressure drops. So that is the way you pick up the systole. It is almost the similar. It is a sharp upstroke, a dome-shaped peak, a relatively high pressure, and you find that in diastole it drops. That is the arterial waveform. Okay. Now, once you have picked up these things, I will not go into details of pressure tracing. These are the important things which are important, which are not taught to postgraduates many times. At least I have discussed with many postgraduates, they are not familiar with calculation of the cardiac output. What is this formula, fixed principle? That is, it is the oxygen consumption in ml per minute divided by the arteriovenous content. Arteriovenous content between the artery and the vein. So the difference in the arteriovenous content, that is the oxygen difference. That is, this much of ml is consumed by the body, and what is the oxygen which has been consumed? The tissues consumed by the tissue. This oxygen consumption is total. So oxygen content is taken as the hemoglobin in gram per liter into 1.36. 1 gram of hemoglobin when fully saturated can carry 1.36 gram. So you have to find out in 1 liter. Okay, that I will give some calculations. Into there is the oxygen carrying capacity, and you have to add the oxygen dissolved in the plasma, which is equivalent to this formula 0031 per millimeter mercury arterial. This we usually don't apply except in pediatric group. Then you have to know the resistance. It is a pressure head. What is the pressure head? To drive the fluid from blood from one point to another, proximal to distal, divided by what is the flow occurring in 1 minute over that area. Pulmonary vascular resistance is the flow which is occurring across the pulmonary capillaries. So it is the mean pressure, pulmonary artery mean pressure minus the pulmonary capillary wedge, artery wedge, or the pulmonary venous mean pressure. That is the pressure head divided by the pulmonary blood flow, or the QP. So that's very important. I think all of you should note down these things. The mean pulmonary artery pressure minus the LA pulmonary vein or pulmonary artery wedge pressure, provided there is no obstruction there between the capillaries and the left atrium, divided by the QP, or the pulmonary blood flow. Systemic vascular resistance is similarly the aortic mean pressure minus the RA or PA mean pressure. Okay, so aortic mean pressure minus the RA. That should be the systemic vascular resistance, divided by the pulmonary systemic blood flow. There is a mistake there. You should know what is the transpulmonary gradient. Transpulmonary gradient. This is the resistance. Transpulmonary gradient is the numerator of this thing. That is the pulmonary artery mean pressure minus the pulmonary artery wedge, or the pulmonary capillary pulmonary venous mean pressure. So that is a gradient across the pulmonary vasculature, mean gradient. That is the transpulmonary gradient. You should also know the diastolic pulmonary gradient. The pulmonary artery diastolic pressure minus the pulmonary arterial wedge mean pressure. I'll come to that again because this needs repetition. Here again, I have told you that the PVR is pulmonary artery mean pressure minus the pulmonary artery wedge mean pressure divided by the QP, aortic mean pressure minus the RA divided by the QS. The transpulmonary gradient is PA mean minus pulmonary artery wedge mean. Diastolic gradient is diastolic PA pressure minus PA wedge mean pressure. I will give you an example and come to that. Then we talk about the resistance and the resistance index. Here you have taken QP or QS. You take the flow, this is the flow index. That is, flow index is taken as the denominator. So let us take a PA mean pressure of 50, pulmonary artery wedge pressure of 10. I am talking about the pulmonary circuit because we are interested more in the pulmonary circuit for calculations. Pulmonary artery mean pressure case is 50. Pulmonary artery wedge or pulmonary vein mean pressure is 10 millimeters. Cardiac output is 5 liters. And body surface area is 1.5 square meter.
As your slide move?
Okay, sorry. Can you now see this?
Now it has come. Okay.
I have discussed the pulmonary vascular resistance and SVR. I have discussed the pulmonary gradient, transpulmonary gradient, and the diastolic pulmonary gradient I have discussed. Now we'll tell the application of that. Now pulmonary artery mean is 50, pulmonary artery wedge or pulmonary vein or LA mean is 10, cardiac output is 5 liters, and body surface area is 1.5. We take the PVR. It's a pulmonary artery mean pressure minus pulmonary artery wedge mean pressure. That is 50 minus 10. Pulmonary artery mean minus pulmonary artery wedge. That is the pressure head, 40, divided by the QP, which is normally this is 5 liters. So 5, it is 8 units. Is it clear now? That is, the pulmonary vascular resistance is the pressure head across the pulmonary vasculature. That is PA mean minus the pulmonary artery wedge mean, that is 50 minus 10 is 40, divided by the QS, that is a cardiac output, which is 5 liters per minute. This is without shunt lesion. So it is 8 units. Now, when we talk about the pulmonary vascular resistance index, which is important in pediatric population, instead of this QP or the cardiac output, you use cardiac index. Cardiac index is 5 by 1.5. So 40 by, so 50 minus 10 divided by 5 by 15. This is the cardiac index. And in arithmetics, this will go as the numerator. So that is how you got the index as the resistance into body surface area. This is the way by which that calculation is got, which some of the students are not familiar. So instead of this resistance, you use, instead of the cardiac output as the denominator, the cardiac output as the denominator, here you use cardiac index as the denominator, which is 5 by 15. And when it comes, this will go up. That is pure arithmetics or whatever it is. So PVR or SVR is the resistance into body surface area. Okay. Now, once you know this thing, next is the normal values. I think you go through the textbook. There is no point in reading all those things. You can take a standard textbook and copy these things. I talk to all the postgraduates. If they have a notebook, in the front page, you have to write all these pressures, because empty number of times, even the senior postgraduates, many times they fail to say what is the normal pressure forms. They may talk about the LV systolic and diastolic, PA systolic and diastolic, but it comes to the atrial pressures, A wave, V wave, they fumble. So this I am not teaching. They should know this. Okay. Now, this is one thing which you should know. That is, in diastole, the pulmonary valve is closed, the aortic valve is closed. The mitral valve is open. There is no obstruction in between. That in diastole, the pulmonary valve is closed, aortic valve is closed. From the pulmonary artery through the capillaries to pulmonary vein, LA, LV, there is no obstruction. So the diastolic pressures in these chambers, this circuit is same unless there is an obstruction. So the LV diastolic pressure equals the LA mean pressure equals the pulmonary venous mean pressure equals the pulmonary capillary mean pressure equals to the pulmonary artery diastolic pressure, with 1 to 2 millimeters rise as you go proximally. That is all. This is very, very important. Now I will give you an example. Here is a 30-year-old lady, class 3 dyspnea. The pressures aortic, LV, all those things I have written. Now I will read for the students. Aortic, 120 by 60, mean 80. Is it normal or not? Many times they say it is normal. But in hemodynamics, the pulse pressure is wide. The diastolic pressure is on the lower side. Keep it in mind. You have to think with the clinical background, is there any situation for a wide pulse pressure? With the clinical background, sometimes it could be normal. It may be an error in hemodynamics. Then coming to LV, it is 125/8. It seems to be normal. Compare with the chamber to which it is communicating. That is, the flow is communicating, because the LV is communicating to aorta in systole. The pressures are almost the same. It is not communicating to the aorta in diastole. So don't try to compare that. Now coming to LA or pulmonary artery wedge is LA, 820/24, mean 18. Obviously, it is high. The waveform is maintained. Now you compare this. the pulmonary vein or the left atrium communicate with the LV in diastole. So compare the mean pressure with the LV diastolic pressure. You find there is a gradient of 10 millimeters of mercury. That means there is an LV inflow obstruction. Now magnitude, we take so many background to say that is moderate or severe based on the heart rate, so many other things. Now coming to pulmonary artery, it is 70/30. Obviously it is high. Systolic is high, diastolic is high, mean is high. So definitely there is pulmonary hypertension. So you have to compare the pulmonary artery with the distal chamber, that is in diastole. I told you that in diastole it is communicating freely. So here is 30, here it is 18. So there is a diastolic gradient of 12 millimeters and a mean gradient of 27 millimeters of mercury. So you find that there is a transpulmonary gradient of 27 millimeters and a diastolic gradient of 12 millimeters. Is it clear? Okay. Now coming to the RV, 80/10. So you find that in systole you have to compare with the PA. 10 millimeters difference is acceptable. In diastole it is 10. We don't compare with PA, but this pressure is a little higher than normal. So you have to say that there is RV systolic hypertension with probably RV dysfunction. Coming to RA, A16, V24, mean 14. So pressure is high. Okay. Then the V is taller than the A. Normally A is taller than the V. So we should look for causes of prominent V wave. Okay. And compare the RA pressure with the RV diastolic pressure. Now you find there is a 4 millimeter difference. Can you see my arrows moving? Can you see my pointers moving?
Yes, sir.
Okay, fine. So you can see that there is a gradient of 4 millimeters. Now you have found there is a wide pulse pressure. There is a diastolic gradient across the LV inflow. There is pulmonary artery gradient with a mean grade pulmonary artery hypertension with a transpulmonary gradient of 27 millimeters and a diastolic gradient of 12 millimeters of mercury. There is RV systolic hypertension with RV diastolic pressure elevation. There is a prominent V wave with a high RA pressure and a gradient. So there is a mitral LV inflow gradient, RV inflow gradient, and pulmonary hypertension. So you have mitral stenosis, diastolic, there is pulse pressure, you have to think of AR, pulmonary hypertension, then RV dysfunction, and a gradient that is tricuspid stenosis with prominent V wave. So these are the conclusions which you have to draw from this. Now you have the saturations. I'll go to the next slide. Okay. Now we try to calculate the case. Cardiac output. Oxygen consumption in ml per minute, 180. That is VO2 is 180. Then arteriovenous content difference. Hemoglobin in gram per liter. 15 gram per deciliter is 150 gram in liter into 1.36. That is the oxygen which can be carried if it is 100% saturated into 30%, 30/100. So oxygen consumption body divided by the oxygen content, hemoglobin in liters. That is 15 gram in 100 ml is 150 gram in 1 liter into 1 gram of hemoglobin can carry 1.36 ml of oxygen. So that is oxygen content. I have excluded that PaO2 and the difference is 30%. So 30/100. This 100 will go and it will come as 3 liters per minute. So cardiac output is 3 liters per minute. Okay. Now the resistance. You have found that the PVR is pulmonary artery mean is 45. The pulmonary artery wedge is 18. That is the difference, 27 divided by 3. That is 9 Wood units. Normally is 1 to 3. Transpulmonary gradient. It is pulmonary artery mean, that is 45 minus the pulmonary artery wedge mean is 18. That is 27 millimeters. Normally it is less than 12. And diastolic pulmonary gradient, that is PA diastolic is 30 minus pulmonary artery wedge mean is 18. 30 minus 18 is 12. Normally is less than 7. This value is very important. Just as what is the type of PAH? type of pH. Okay. The type of pH, when the mean pulmonary artery pressure at rest is more than 25 millimeters of mercury, some people now put it as 20, especially when it is coming to idiopathic pH. If the pulmonary capillary bed pressure is less than 15, left heart is normal, so it is pre-capillary. If it is more than 15, it is post-capillary. Now, is it purely post-capillary passive? You look at the PVR, should be less than 13. The transpulmonary gradient should be less than 12, and diastolic pulmonary gradient should be less than 7. Then you can say it is purely passive pulmonary hypertension. In a patient with mitral stenosis, has the pulmonary vasculature reacted? In that case, the pulmonary vascular resistance will be more than 3 Wood units. The transpulmonary gradient will be more than 12 units, and the diastolic gradient is 7 millimeters more, indicating that there is a resistance at the pre-capillary level also. So this is a post-capillary with a reactive or disproportionate pH. Okay, this is simple. I think I will not go to that. I can skip that. And now I'll come to a congenital heart disease. Okay, this is a 22-year-old female. Okay, this is the oxygen saturation 96 iota, right atrium is 53, PA is 91, pulmonary vein is 97. Okay, the pressures, this I have taken only for calculations. Okay, pressures PA 85/25 mean of 50, pulmonary vein mean of 10, oxygen consumption 118 and hemoglobin 18. Now, how will you calculate the QP/QS? You can calculate the flows and ratios can be calculated because the oxygen consumption is a constant. You take this, the reverse of that is systemic arteriovenous difference divided by the pulmonary arteriovenous difference. Systemic is aortic minus right atrium, 53, that is 43. The pulmonary is pulmonary arterial minus this difference between the pulmonary artery and the pulmonary vein, it is 6. So 7:1. That is the QP/QS. That is the ratio. Left right shunt is 7:1. Now, how can you calculate the QP? The oxygen consumption divided by the pulmonary arteriovenous oxygen content difference. Similar to that, 180 minus 150 into 1.36. That is 15 gram is 150 gram in 1 liter into 1.36. And what is the pulmonary arteriovenous difference is 6%. So 6/100, which will come to 14.7. Similarly, you can calculate the systemic blood flow. Instead of this pulmonary arteriovenous oxygen content difference, you have to 6 aortic minus right atrium. It is you have to take that difference and calculate. Now, this patient has pulmonary arterial hypertension. Obvious. Now, the pulmonary arterial hypertension is pre-capillary because the post-capillary pulmonary venous pressure is normal. If this has been more than 15, you think of post-capillary also. So this is a pre-capillary pulmonary hypertension. Now you go for the PVR. Pulmonary artery mean pressure is 50 minus the pulmonary mean pressure minus the pulmonary vein. Okay, sorry. Okay, the pulmonary artery mean pressure minus the pulmonary vein pressure is 40. That is 50 minus 10 divided by the pulmonary blood flow, which is 14.7 units. It is 2.72. In adults, we need not bother very much about the index, but you can multiply it by the body surface area to get the PVRI. Okay, I'll take a few examples of oximetry. Now, this is the oximetry, 2 samples. Just to illustrate a few examples only. Look for the pulmonary artery aortic saturation. That is my first step. Normally, pulmonary artery saturation is less than aortic. And suppose this was 70, the difference we have to calculate. Normal systemic AV difference or the arteriovenous oxygen difference is 20 to 25. If it is narrow, that means hyperdynamic circulation or left-right shunt. If it is wide, low cardiac output or right to left shunt or desaturated situation. So that is the first thing. Arteriovenous oxygen difference, it should be normal 20 to 25%. If it is more than 25%, that means the cardiac output is low. or there is a right left shunt or a desaturated situation. If it is very narrow, it means a hyperdynamic circulation or a left-right shunt. Now here you take, both are same. What are the situations where both are same? You have only 2 entities or 3 entities. Once both are same, look at the next proximal chambers. That is the left ventricle and the right ventricle. Here, those are also same. That is, both the great arteries and both the ventricles are the same. Next, you look still the proximal chamber, right atrium and the left atrium. Now you find that aortic and PA are same, the ventricles are same, and atria are same. That is same in both great vessels, same in great vessels and 2 ventricles, same in all 4 chambers and the great arteries. Okay, that's very clear. Here you find the aortic is 70, pulmonary artery is 90. That is, pulmonary artery is greater than aortic. Okay. Now I will tell the conditions. The conditions. One, PA saturation more than aortic. Classically, it is DTGA. Toxic big anomaly, which physiologically is DTGA or TGA, the circulation. And minor increase in the PA saturation can occur in a supracardiac TAPVC. It's only 2 to 4%, nothing great. Both are equal. Both are equal. There is aorta and pulmonary artery is receiving blood from one great artery, atresia of either semilunar valves, commonly pulmonary atresia, where both the ventricles will empty to the aorta, and that will provide blood to the pulmonary artery through AP collaterals or through a BT shunt or whatever it is. Truncus, theoretically, but there will be streamlining, so less likely to have equal saturation. But some examiners want truncus also to complete the list, but there will be streamlining, so it will not be equal. This will be equal in atresia. Then pulmonary artery, aortic, and 2 ventricles equal means the univentricular physiology. The whole blood, the systemic and pulmonary venous blood is received and mixed in the ventricles, and it is emptying to the great arteries. Classically, mitral atresia, tricuspid atresia, the commonest. Single ventricle, again like tricuspid atresia, by definition, it need not be that the 2 ventricles, that is, 1 ventricle is receiving the whole blood. More than 1.5 drainage can be taken as single ventricle physiology. So it may not be, but you can tell that as an answer. It is a univentricular physiology. Commonest is tricuspid atresia. Then you can take single ventricle of different types. Mitral atresia rare. Then equal saturation atria, ventricles, and great arteries. That is TAPVC. Okay, I will have the last slide. That is, you have that what is called is the transposition of great arteries. Students are not at all familiar, except very few students who have been trained in congenital heart disease, probably the pediatric fellows. This is transposition. You have the vena cava with the desaturated blood coming to the right heart and the pulmonary venous blood coming to the left heart. Then to survive, there should be intercirculatory mixing of almost equal volume. One region cannot be flooded. It should be balanced. So what happens is part of this venous blood will go to the left heart. So this is thing, and that will go to the pulmonary artery for oxygenation. Now let us take this. The saturated blood coming from the pulmonary vein to the left heart through a VSD or a ASD, whatever it is, part of it will go to the right side. So this is anatomical left-right shunt. That is, from the left it is going. It is saturated blood which is going from the left side to the right side, and that goes to the aorta. So that is the effective systemic blood flow. That is the oxygenated blood which crosses and goes to the tissues. That is the effective systemic blood flow. That is the anatomical left-right shunt is the effective systemic blood flow. And similarly, or on the other way, the venous blood coming to the right heart, part of it goes to the left heart. So it is an anatomical right to left shunt. And that will go to the pulmonary circuit for oxygenation. So it is the effective pulmonary blood flow. And there is oxygenated blood is going to the pulmonary arteries, the physiological left-right shunt. Left-right shunt means oxygenated blood is going to the lungs. So this one, C is the physiological left-right shunt, but it is not anatomical. Anatomically, it is going straight. So this is the physiological left-right shunt. This blood, venous blood, which is going to the aorta, is the physiological right to left shunt. There is nothing anatomical. Vena cava to right atrium to right ventricle to say it is going to the aorta. Okay, so that is the physiological right to left shunt. Anatomically, it is straight going. There is no crossing. There is no crossing from left or right. Here we are talking about left, right, anatomical and physiological. Then, so what is happening is the oxygenated blood on the left side crosses to the right side. So that is the anatomical left-right shunt. But that is oxygenated blood going to the aorta. There is the effective systemic blood flow, QES. Now, this remaining blood, which is going to the pulmonary circuit, is recirculating. That is, from the left heart, it is going to the pulmonary artery, means physiological left-right shunt. And the venous blood coming to the right heart goes to the left heart. So, anatomical left-right shunt, and that will go to the pulmonary artery for oxygenation. So, the effective pulmonary blood flow. This blood, which is going straight without any shunting anatomically going to the aorta, is there is a venous blood going to the aorta, is the physiological right to left shunt. I think the juniors, the residents have to go through it again and again, because nobody is training you, teaching you. I think at least some of us are teaching you, but many times they are skipping these things. If I am the examiner, I may ask. Fortunately, I am not the examiner. I may ask this thing. I think I have taken 30 minutes or more than that.
Sir, could you show your saturation slide again?
The previous one?
No, the first one, the saturation. You have shown the saturation. I think 3 or 4 slides ago, 20th slide.
This one?
This one.
Yeah. Oximetry, I'll take the previous one. I'm just putting at this, I think you can see. First is compare the aortic and pulmonary artery. That is the first thing. To look for arteriovenous oxygen difference. In all situations, arteriovenous oxygen difference is very important. Okay? Because even in microstenosis or any heart disease, we have to see what is the cardiac output. Roughly, you get an idea. Hyperdynamic circulation, low output, high output, left, right shunt, all those things you get an idea. That is wide or narrow. Here it is same. Once it is same, look into the proximal chamber, that is the ventricles. Here, both great arteries and both ventricles same. Next, you go for still proximal, that is atria, ventricles, and great arteries, all are same. So the previous one, here it is, the aorta and pulmonary artery is getting the blood from a common source, single source. So commonly it is pulmonary atresia, rarely aortic atresia because they seldom survive. Truncus arteriosus described, needed by the examiners, but it will not be same. There will be streamlining because anatomically the vessels are oriented. It is not like transposition. They are oriented normally so that the right ventricular blood is likely to go to the pulmonary artery and left ventricular blood is likely to be preferentially given to the aorta so that the saturation may not be same. Here, the ventricle has, the blood has mixed, the venous, systemic and pulmonary venous blood has mixed in the ventricles. So it's a univentricular physiology. That is the, not physiology, it's a univentricle. That is, the single ventricle is functioning and receiving blood from both great atria. Classically, it's tricuspid atresia, because there the mixing occurs in the left ventricle. The right atrial blood and the left atrial blood comes to the left ventricle in diastole, it mixes. Then it empties to the aorta or through a VSD to the pulmonary artery if it is normally related great arteries. Mitral atresia, the same thing in the opposite direction. Single ventricle, I have some reservation because single ventricle by definition, I don't know, that is what I know. That is by definition, more than 1.5 AV valve drainage can be taken as a single ventricle physiology. It need not be that both the AV valves should completely drain. There will be a rudimentary ventricle also. Sometimes there may not be. Okay. Then if all the chambers are same, then obviously the mixing has occurred in the atria. classically TAPVC. Single atrium also, it is very unlikely, even though the examiners want that. But single atrium is like a large atrium. RV is more compliant. So what happens is left atrial blood is preferentially likely to flow to right atrium, and right atrial blood will go to the right. So just like ASD, there will be some mixing, but it will not be same. Some examiners want single atrium also as the answer. Then once you have that TAPVC, then how to know it is supracardiac, cardiac, or infracardiac? You go for the venous saturation. If the superior vena cava shows a high saturation, it is supracardiac. If the IVC or the hepatic vein shows a very high saturation, it is infracardiac. If both are normal, but the atrial saturation is equal, that means it is intracardiac. I think you can contribute to these things. We have the other faculty also if time permits. Because Rao sir is there, Dr. Venu is there. I have a few more slides. I don't want to go beyond this now. Is it okay, Jabir?
8:15.
Yeah.
Jabir's presentation is also there. No?
Yeah. Okay. If
No,
the
I think you can ask the postgraduates to send their queries in the chat box or.
Okay, there is one.
Hmm.
I think by the time he prepares that slideshow, okay, fine, that's nothing.
I have only 5 questions, sir. That is the quiz, 5 questions. Each question, it is 30 seconds. Naveen?
Yes, sir.
Once you start showing the slideshow, yeah, each question is 30 seconds.
Okay, sir.
All right. So,
Yes, sir.
okay. Start the timer.
Yes, sir. Doctor, post your answers in the chat box, doctor. Sir, I'm up, sir.
Okay. So this is a 30-year-old male with history of palpitation and syncope.
Yes, sir. Yes, sir. Over, sir. I'm up, sir.
Which simple blood test can help the diagnosis? Sorry.
Yes, sir. I'm up, sir.
Right.
Yes, sir. Yes, sir. I'm up, sir.
All right. Sudhayakumar sir, would you like to discuss it?
This one I don't want.
Anybody is correct? This is at the systole, where the impulse is in the systole during the later part. It's a cardiac contractility modulation where a high voltage, long duration signal is given to the right ventricular septal wall during the what you call it is the biphasic electrical signals are given during the absolute myocardial refractory period. The ECG will look like this. Any correct answer?
So what is the answer, sir? Correct answer?
Cardiac contractility modulation.
Okay.
No, I think it's tough for us.
Sorry.
This is the second. That I think Sudhayakumar.
that's
No, this was used as a therapy before the era of CRTs and other things.
That is
Yeah.
CRT, right, sir? Answer is CRT, yeah, sir.
No, the answer is cardiac contractility modulation.
Cardiac,
Okay.
electrical modulation of cardiac contractility.
No, sir. No one given, sir.
This is the second. It is young patient with
This they
history of
should
cardiac.
answer. This they should answer.
Yeah, that is.
I
This
think
is
it's very quick. You can say that.
This is epsilon waves, no?
Epsilon wave.
And
Yes,
ARVC.
there's a clear-cut epsilon wave seen.
Epsilon
Anybody
wave
has
is a-
given the correct?
I'm sure the many should have given.
Yes, many people have given, I think.
And there
How
will be
many have
right
given?
impulse.
If arrhythmogenic right ventricular dysplasia or arrhythmogenic right ventricular cardiomyopathy.
Yes, sir, many given, sir. The first answer, correct answer given by Dr. Suhas Alu.
Okay.
Okay.
The third one.
Which simple blood test can help to diagnose?
So what you are seeing is the atria is dilated, the right atrium is dilated more than the left atrium, and both the apex is obliterated. And you can see in the MRI it is dark, so that means it is thrombus. So, sorry, it's the biventricular thrombus. This is commonly seen in eosinophilic cardiomyopathies. Most important, the blood test that you have to look at is a peripheral blood eosinophilia.
You have asked for the simple blood test. So I'm right that I will put as peripheral smear for eosinophilia.
Yes.
Okay. But my diagnosis was not eosinophilic endocarditis. My diagnosis was EMF. That
Yes.
is-
Myocardial fibrosis, but
But
the
by-
MRI is these dark is more in favor of thrombus.
Yeah, that's I agree. But your question was with simple blood test, I am right. Okay. But my diagnosis was EMF.
Yes, I also agree. I thought it was EMF, but I was thinking, what is a blood test associated with the
I was eosinophilia.
A
because-
blood test associated with this, I think there was a previous data of blood. It is not arsenic. There was some toxic.
No, actually, this is first described by Davis.
Yeah, that is.
Eosinophilic. This is even before endomyocardial fibrosis came.
Yeah.
Okay.
Venu sir, I think it was CCM. What was the toxic material in endomyocardial fibrosis people have looked at? Is it CCM?
No, that is cerium. That is a different hypothesis.
Okay.
No.
Any
So
correct answer?
this
The
Yes.
answer is eosinophilia, sir.
eosinophilia.
Right.
Yes, sir.
Yes.
Dr. Simna, sir.
Okay, fine.
Okay,
Next.
good.
Next.
So this
is concertina effect.
if somebody has written atrial tachycardia with AV block, that is the best answer. If it is atrial tachycardia also, I may accept. You can see in the 1, 2, 3, 4, 5. The fifth cycle, you can see the 2 P waves. And in between the P wave, the isoelectric interval, there is a horizontal isoelectric interval. Had it been an atrial flutter, there should not have been an isoelectric line. So this must be atrial flutter versus atrial tachycardia. The rate of the atrial rate it is 7.
Yeah, it's around 220.
Yeah.
Yeah.
But there is a definite isoelectric line.
Yeah, there's a definite isoelectric line. So I'll prefer atrial tachycardia with something like an AV block, which is not consistent, a varying AV block because the cycle length is varying. So atrial tachycardia with AV block varying, rule out digitoxicity, but there are no other findings of digitoxicity. So atrial tachycardia with the varying block will be my diagnosis.
Okay.
Next one should be simple for them.
Yes.
This is VT.
It's a right bundle branch. It's a broad QRS regular tachycardia. right bundle branch block pattern, left axis deviation. So it is a right bundle, left axis. With, you can see it's a ventricular tachycardia because there are evidences of AV dissociation and one capture beat.
Yeah.
Capture bits.
Yes. Sure.
Capture bits.
Yeah.
1, 2, 3, 4, 5, 6. The sixth beat is a capture beat.
Yes.
Yeah.
And you can see independent P waves also.
Independent P waves
Yes.
also. This is a left fascicular tachycardia.
Yeah. Posterior fascicular tachycardia. Okay,
Okay.
fine.
So what is
Any
the correct answer,
correct
sir?
answer?
Capture beat. Capture beat is a correct
No,
answer.
diagnosis is posterior fascicular tachycardia.
Ventricular tachycardia, fine. Left fascicular tachycardia is the correct answer.
Okay, sir.
Posterior fascicular tachycardia, they have to write.
Yes,
Somebody
okay.
might have written Belassen's tachycardia. That tachycardia, Belassen's, it is not labeled like that. The articles are by Belassen's, but I could not get a terminology Belassen's tachycardia. The Belassen's articles have been there on this thing. So the correct answer will be posterior left fascicular tachycardia, left posterior fascicular tachycardia. That should be the most appropriate diagnosis. Pure VT, I may not give full marks.
No,
Doctor,
it's not a pure
Simna-
VT. It is.
Yes.
It has to be a fascicular ventricular tachycardia.
Fascicular.
Fascicular VT.
Dr. Simna given correct answer, sir. Left to posterior fascicular.
Yeah, that's it.
Yes, sir.
That's the correct answer.
Yes,
Yeah.
sir.
That's the best answer.
Okay.
Okay.
Okay, fine. Okay.
The QRS duration of fascicular VT may not be as broad as a
And
conventional.
what I
ventricular
think, that is
tachycardia.
right. The QRS
That's a point usually some people use to distinguish. The QRS duration of fascicular VT may not be as much as a classical or conventional ventricular tachycardia.
And it usually follows a RBB pattern as such. That is,
Yes.
the R prime is taller than this thing, and the rate
Yes.
will be usually a little slower side, like 130, 140, 150. Okay, fine.
Shall we go for the case presentation, sir?
Yes.
Dr. Anwar, our postgraduate, will present it. He is the DNB resident, final year DNB resident of PC Hospital, Kochi. Anwar,
The main moderator will be Dr. Venugopal and Rao sir. Okay.
No, I think today you have to excuse me. I have a very bad cough. I listen to it. In which if I start talking, I'll start coughing also.
Because I have been
Rao sir is there. No, no, Rao sir, I'll chip in between.
We have been screwing him regularly.
Okay. Mm.
Okay.
Okay.
Anwar,
Dr. Anwar, sir. So what is the name you are logged in, sir?
Yes.
Okay.
Anwar, I can see him.
Yes, sir. Yes, sir. You can share now, sir.
Anwar, you can start.
Yes.
Presentation mode.
Good evening, respected teachers and friends. I'm Dr. Anwar, DNB trainee from this.
I think
Echo is there. I think Dr. Anwar there is there any other?
Presenting the story of a 72-year-old male from Kottayam, which is a coastal area in Kerala. He was in
Kottayam is not a coastal area.
exertion
Kottayam is not a
palpitation from the
coastal
age
area.
of 10 years and dyspnea on exertion class 2 with additionally irregular palpitation for past
There is,
22 years.
excuse me, there is an echo in your presentation.
For which surgery was advised
Dr.
but
Anwar, sir.
not done. For past
Dr.
4
Anwar,
years,
sir.
he complains of dyspnea on exertion class 3 with bilateral pedal edema without orthopnea and PMD. Now came for follow-up. Come to his present illness. He was born out of a non-consanguineous marriage. He was asymptomatic till the age of 10
No,
years.
you are not audible.
He started experiencing exertional palpitation at the age of 10
Can you just
years.
go back to your first slide, please?
Slow onset and offset with no associated pre-syncope or syncope. He was not on any medication. And he used to play with children of same age group in school. There was no history of any restriction of activities. And there was no significant worsening of symptoms till the age of 50 years. No history of cyanotic spells or squatting episode. He was a driver by profession and used to go for work regularly. At the age of 50 years, he started experiencing shortness of breath on his routine activities like going to shop for buying groceries, etc. No history of associated orthopnea, PND, angina. No history of pedal edema, abdominal distension, or facial puffiness that time. And he started experiencing irregular fast palpitation also without any history of syncope or pre-syncope. A detailed cardiac evaluation was done at that time, including echo. He was diagnosed with a heart disease for which surgery was advised, but he was not willing for the procedure. And at that time, a coronary angiogram was also done, and he was diagnosed with a coronary artery disease for which medical management was advised. He was put on regular routine medications, including anticoagulant. And he remained in NYHA class 2 for next 18 years without any history of angina, PND, pedal edema, no history of any hospital admission during this, no history of prolonged fever or neurological symptoms. For past 4 years, symptoms worsened to class 3 with bilateral symmetrical pitting type of pedal edema extending up to ankle. It was not associated with PND or orthopnea, no history of syncope. There were past medications. No history.
Anwar, can you just summarize the present history in 4 sentences?
Yes, sir. It's a 72-year-old male with exertional palpitation from childhood with history of dyspnea annexation class 2 for past 20 years with additional arrhythmic palpitation. Now with worsening of symptoms to class 3 with pedal edema for past 4 years.
Any idea what was the nature of the disease during the childhood?
So the history was taken from the patient itself. He says that he was completely asymptomatic till the age of 10 years.
But exertional palpitations, was it a arrhythmic palpitation or was it a volume overloaded ventricle that was causing it? Or was it anxiety? What was it? I think you need to describe the nature of what you labeled as palpitation.
But it was regular palpitation, more like volume overload palpitations. Increase aggravated by exertion.
So he was aware of the heartbeat, not the.
Yeah.
Was it a rapid heart action, or was it only he was aware of the heart beating?
He was aware of the heart beating.
And you also said exertional palpitation. Did you mean that it was becoming worse on exertion, or was it felt only during exertion?
It was felt only during exertion, sir.
So what are the possibilities to have had a disease that was that is suspected during the childhood, gone on to live, the patient went on to live till the age of 72 years?
He became symptomatic from the age of 10 years. But
10 years to 72 years, almost 60 years, 60 years of long course. So what kind of diseases are possible that will last that long without causing him much of disturbance?
It's a congenital heart disease.
Like?
A cyanotic.
Like what? A cyanotic congenital heart disease going on to survive till for the next 60 years without much of problem, and is a professional driver and able to lead a normal life.
There are shunt lesions like.
Now you said congenital heart diseases. What type of congenital heart disease is going to have that kind of a benign course?
Shunt lesions, probably AST can present later, third or fourth decade. Hemodynamically insignificant VSTs.
But as per the history, is dominated by arrhythmias, according to your history.
Yes, from 50 years onwards.
During childhood also they had palpitation.
Yes, that was like a exceptional volume overload palpitations.
So apart from congenital heart diseases, what are the other diseases that are likely to be? That will have a long
Valvular heart diseases, mitral,
mitral.
Would you consider an obstructive lesion or a regurgitant lesion with such a long history?
regurgitant lesions.
Regurgitant lesions.
Mitral,
Okay.
yes. Mitral valve collapse with mitral regurgitation.
Okay.
Anything
Other
else?
possibility? Other than mitral regurgitation, any other possibility? Because we discussed a valvular heart disease.
Yeah.
Yes.
It's a
Aortic
long
regurgitation
history,
possibility.
long history.
Aortic regurgitation, by this time, the patient will be more symptomatic.
Why?
Is the rate of progression of aortic regurgitation faster than the rate of progression of aortic stenosis?
Which progresses faster? Aortic stenosis progression or AR progression, which is faster? There is a question.
Aortic stenosis.
So what is the longest duration of asymptomatic period? Which one? Out of the two, mitral regurgitation, aortic regurgitation?
Mitral regurgitation.
If it is only mild, probably will not have any. Why does it become worse at the later part of the life? Either mitral regurgitation or aortic regurgitation.
Maybe due to LV dysfunction.
LV dysfunction? Why LV dysfunction? What makes you to say LV dysfunction? LV dysfunction may be a consequence of the regurgitation. So what factors determine the degree of regurgitation in mitral or aortic? Three important determinants of the valvular regurgitation. What are they? Or how do you bring out a regurgitation? Let us say it is only mild mitral regurgitation. How do you make it more severe by physical examination? So-called dynamic auscultation.
By dynamic auscultation by hand grip.
Hand grip. How does that worsen the regurgitation?
And the afterload increases.
Yeah. So there must be, if there's an increase in the afterload, so which condition cause increase in the afterload with the passage of years, starting from young age of 20 to the age of 60? Which cardiac conditions or cardiovascular conditions?
Systemic hypertension.
Good.
No, essential hypertension. So that's basically, what is the prevalence of hypertension in the general population?
30%.
Huh? How much can you speak it out loudly and clear?
How much?
So not a,
30%.
Okay.
it depends upon the age, but probably by the time you reach the age of 60, maybe 25 to 30%. By the time you reach the 80, it may be 50%. So it is age dependent. If it's a very young age, probably the hypertension is very less frequent. So one of the factors that might be contributing to the overt manifestation of a possible regurgitated lesion is the occurrence of hypertension, which it occurs in many. Was there a family history of hypertension here?
No.
So apart from the, he had palpitation from childhood and then progressive dyspnea.
Yes.
Once they develop dyspnea in regurgitant lesions, what is the natural history?
Once they develop dyspnea, there will be rapid worsening of the symptoms.
So what is the mechanism of dyspnea in these regurgitant lesions?
pulmonary venous congestion
Due to
increased
Easy.
arterial pressure.
in case of mitral regurgitation, it is probably worsening mitral regurgitation. But is the LA pressure very high in mitral stenosis or mitral regurgitation? So in this patient, mitral regurgitation, you think the LA pressure will be very high to cause dyspnea on exertion? Or something else might be happening?
Patient may develop arrhythmia before.
Arrhythmias. Arrhythmias and mitral regurgitation, probably not so common unless it is rheumatic etiology or a mitral valve prolapse. So that is, and mitral valve prolapse is more commoner in males or females?
Females.
Females. So apart from the valvular regurgitations and congenital heart disease like ASD, what are the other possible causes? Symptoms starting early, and you said it is a volume overloaded ventricle and history of arrhythmias in the later part of life. Tell me what type of heart diseases arrhythmias are more common in the adults.
Ischemic heart disease.
Ischemic heart disease. Did you say that?
Valvular heart disease, mitral stenosis.
No, that is rheumatic, we said. But is there any other diseases you know of wherein arrhythmias is a prominent feature in the natural history of the disease?
Cardiomyopathies, hypertrophic cardiomyopathy.
Hypertrophic cardiomyopathies, going on such a benign course, starting very early in childhood. The earlier the onset of HOCM, the more worse is the prognosis. Can you think of Epstein's anomaly?
Yes,
Is it possible?
yes, that's possible.
Okay. Any other diseases which can cause where the arrhythmias are a prominent feature or a?
Yeah, you have also discussed, we discussed hypertension as one reason for the worsening. I think you have already told us that he had a coronary angiogram. He also had some obstructive lesions. So I think ischemic heart disease, underlying ischemic heart disease should also be a contributing factor for the worsening of heart failure in this patient. The other point is that you are discussing AR and MR, and you also discuss about atrial fibrillation. So between AR and MR, which lesion is more likely to have atrial fibrillation? If we are discussing AR and MR, the same duration, which is likely to cause atrial fibrillation?
No, I will ask the question. I will ask the question in a different way. In a patient with AR, should you find atrial fibrillation? What is the etiology of atrial fibrillation? That means you have missed out a mitral valve disease. Because atrial fibrillation is very uncommon, especially in the younger and middle-aged group, to have in cases of aortic regurgitation. If you find atrial fibrillation and aortic regurgitation, that means there is a possibility that there's an underlying mitral valve disease which was missed by clinical examination. Okay. Any other arrhythmias per se causing these problems in the later part of the life? Primarily arrhythmias which go on persisting and then cause
Tachycardiomyopathies.
cardiomyopathy going on for so many years from the childhood. Okay, you said only dyspnea, but no PND.
No PNDs.
No PND. And so what is the nature of the disease? Is it a left-sided disease or a right-sided disease or a combined disease?
I consider left-sided disease.
Consider left-sided disease even though there is no
But
There
there
is
is
no
no
evidence of PND.
no orthopnea PND, sir. So
More
in
likely to be right-sided
right
disease.
side, right side.
Okay, go on.
Okay, sir. Shall I act as a student also?
Sure, sure.
The way I will be discussing this case, because we have to give some message to the students also. If I am the candidate, how I will present? Sir, the points in the history, asymptomatic up to 10 years. From 10 years also onwards, exertional palpation only without interfering with the patient's activities. Symptomatic from the age of 68, am I right? No, up to
No.
50 years, where the patient has developed irregular palpitation. And then class 3 for the last 4 years with the CHF.
Yeah.
So, sir, I will be discussing like this. Is symptomatic from 10 years, asymptomatic 10 years. I first go for a congenital heart disease. Second is another disease which can manifest by the age of 10 years like valvular heart disease. And I will think of a condition which can have a long asymptomatic or minimally symptomatic phase going for deterioration. That is one part. Second is the palpitation. I will say straight away it is a non-arrhythmic palpitation to begin with. Whether it is volume load or otherwise, I am not sure, to be very frank, because he said only exertional palpitation. Volume overload should have palpitation even at rest, exaggerated. But discussing on a palpitation which is non-arrhythmic, I think specificity is very low. So I may not give too much significance to that palpitation because it is a non-arrhythmic. If you take it as a volume load, my diagnosis will be limited to few things. Then 50 years onwards, he got irregular fast palpitation. The commonest I straight away say will be AF. And now the patient has gone in for CHF. So a long history, relatively asymptomatic, developing atrial fibrillation in 50s or 60s. That is the thing. So first thing I will consider congenital heart disease because it was diagnosed. When was the surgery indicated? At what age was the surgery indicated?
At the age of 50.
At the age of 50. So congenital heart disease I will take. Sir, obviously I am dealing with an acyanotic congenital heart disease because the patient had a good effort tolerance, no cyanosis, nothing. And the limitation is lack of in history of infancy and early childhood. That you have to tell. There is a limitation of history. So asymptomatic, I have 3 obstructions and 3 shunt and miscellaneous like Epstein's always you have to keep in mind. In a congenital heart disease, Epstein's have to be kept in mind because they can remain minimally symptomatic. They can worsen in later period. So among the 3 obstructions are aortic stenosis detected, the progression is fast, so less likely. Pulmonary stenosis can have a slow progression. It can be detected and later they can present with heart failure. Coarctation less likely because if they are detected, it will be diagnosed, managed, no history of hypertension. Among the shunt lesions remaining asymptomatic for quite long and presenting with atrial fibrillation in the 50s and 60s, the commonest is atrial septal defect, where they can have volume loaded ventricle, they can remain minimally symptomatic, they develop atrial fibrillation by 50s and 60s, and they can go in for congestive heart failure without orthopnea and PND. So with the history, my first possibility will be ASD going in for AF and CHF. That will be my first possibility among the congenital heart disease. Second, valvular heart disease, as we have discussed, the valve disease, which is very common, which can be picked up by 10 years, is mitral valve collapse, which can remain minimally symptomatic. Palpitation is a very non-specific symptom, and they can develop deterioration in the later phase, as Sir said, remaining asymptomatic and rapid deterioration because of 3 things. One is, as Sir said, development of hypertension. Second, as Dr. Venu said, associated ischemic heart disease. Third is development of atrial fibrillation. These are the 3 situations where there is a rapid worsening. So I may consider mitral regurgitation due to mitral valve collapse as another possibility. But when they go in for congestive heart failure, I expect them to have paroxysmal nocturnal dyspnea, orthopnea, all those things. So, but when they develop right heart failure, these symptoms may be little attenuated. Then regarding AR, as discussed earlier, it is much less common compared to mitral regurgitation in childhood. Okay. Otherwise, the natural history could be the same, but AF strongly favor mitral valve disease. That will be my this thing. Any other thing, sir? The other thing would be a cardiomyopathy. A cardiomyopathy which can have a long course going for decompensation is hypertrophic cardiomyopathy. As sir said, it can be detected by 10 years, but a hypertrophic cardiomyopathy diagnosed as 10 years, then their survival, their quality of life, everything will deteriorate, but they can remain minimally symptomatic and they deteriorate later because of multiple mechanisms, diastolic heart failure, systolic heart failure, atrial fibrillation, all those things. The next was arrhythmia and heart failure. So this arrhythmia is a late natural history sequence of this disease rather than a primary arrhythmogenic entity. Which are the heart diseases which can present with arrhythmias? Congenital heart disease, young is Epstein's anomaly. They can remain like that, but I expected the patient to have arrhythmias quite early. This patient developed arrhythmias only later. And what is the genesis of arrhythmia in Epstein's anomaly? Anwar, one question to you. Genesis of arrhythmia in Epstein's. Why do they develop arrhythmia? Why they are more prone for arrhythmias among the congenital disease?
Are there any conduction system disturbances?
Dilated right atrium.
No, pre-excitation associated and large right atrium. Two factors.
No.
One is the
Both,
pre-excitation.
both pre-excitation and dilated right atrium,
Right
both can
atrium.
cause atrial fibrillation.
So the point is, when there is a large atrium, the atrial focus, the discharge will be there. And there is a pre-excitation, so they are likely to develop tachyarrhythmias. But when they develop, usually their rate will be fast. But they can have associated AV nodal dysfunction also, so that the rate need not be very fast in elderly with the atrial fibrillation and a dilated right atrium. So that is the way I discuss. Other diseases, the chance is very, very unlikely or very low. Many questions I will not be able to answer, but you have to approach like this. The heart disease is 10 years, minimally symptomatic up to 15 years, development of AF at 15 years, and later going for congestive heart failure with systemic venous congestion more than the pulmonary venous congestion. That will be my approach to the analysis of the symptom. Coming to the diagnosis, congenital, I will vote more for ASD. Then otherwise, Valder, I will go for mitral collapse with mitral regurgitation, and any heart disease coming at any age group with heart failure and arrhythmia, Epstein's have to be considered. Among the cardiomyopathies, I may consider hypertrophic cardiomyopathy as a low list. The hypertension is not the primary disease, it might have contributed. That's the way I will discuss. Okay, sir.
In the interest of accuracy, just wanted to know the opinion of the faculty. Does pulmonary valvular stenosis ever progress?
Sir, to my information, but it's a pediatric cardiology question. They may come with a critical pulmonary stenosis in heart failure, which has to be managed.
Yeah.
The rate of progression of pulmonary stenosis valvular is very slow compared to aortic stenosis. That's all what I know.
It is often what you call discussed that the pulmonary stenosis, pulmonary valvular stenosis, is stable at whatever level they are born with. That they rarely progress beyond that level. So if it is a mild PS, they will continue to remain as mild PS. But progressive pulmonary valvular stenosis probably may occur only in acquired conditions like these carcinoid syndromes. But congenital pulmonary stenosis, if I understand correctly, is, it does not progress at least at the same rate. By and large, it's supposed to be static. Okay, I think let's move on to the
data. This is the statement which he has given. The rate of progression of valvular stenosis, once it is mild, is very slow and much slower compared to aortic stenosis.
Yeah.
Okay, fine.
Yeah, we'll go on to the physical findings.
On examination, he was cooperative, comfortable, sitting in bed, not dyspneic or tachypneic, with a saturation of 97% in room air, with a BMI of 20. No pallor, cyanosis, clubbing, or lymph node enlargement. There is bilateral symmetrical pitting type of non-tender pedal edema extending up to ankle. Pulse rate was 70 per minute, which was irregular, varying volume, normal character. Apex pulse deficit was 8. No radioradial, radiofemoral delay. All peripheral pulses palpable. Blood pressure was 130/70 millimeters of mercury in right upper arm sitting position, 130 millimeters systolic in lower limb. Respiratory rate was 18 per minute, which was abdominothoracic. He was afebrile. And this was the JVP. So, mean pressure elevated 13 centimeter above clavicle.
Wait. Can you ever measure mean pressure at the bedside?
I
I
always
think,
I taught you that you should not use the term mean pressure.
yeah.
You will be in trouble.
Okay, second thing, the problem here is, and then did you say that, if I understand you correctly, you said the BP is 130/70. Did I hear you correctly?
Yes.
So it's a pulse pressure of how much? 60.
60.
Yeah, okay. And a pulse pressure of 60, you said volume of the pulse is normal. Did I hear you correctly?
You can tell because didn't say normal, varying pulse volume. He did not say overall whether it is normal. He said the normal in character. He did not say the volume whether it was overall normal, high or low. You should tell that.
No, but in a patient with congestive heart failure, do you expect a pulse pressure of?
No, sir. Low pulse.
And then if it is there, then what are the things you should consider?
Aortic runoff.
Aortic runoff. That's the only answer you have?
What is the most likely explanation in this person? Basic demographics.
What does the pulse pressure really reflect? Why do you get a large pulse pressure in aortic regurgitation?
The diastolic pressure will be low due to aortic
No,
runoff.
diastolic pressure is low, but the pulse pressure is wide. So, how do you suspect a high output state?
Volume overload state.
Volume overload, high output stage. I think it is important to remember for the students that pulse pressure is a reflection of two factors. One is stroke volume, other
Yes.
one is compliance of the blood vessel. So in a patient who is suspected of having symptomatic congestive heart failure with a wide pulse pressure, your diagnosis should shift slightly to one side to explain these things, Okay, go ahead.
You have to keep in mind the age-related changes in the blood
Yeah.
pressure. So you have to keep
Exactly.
in mind. Because
For a 70-year-old man, yes,
yeah,
really,
you find that the patient's systolic pressure would have been high and it might have come down. So
yes.
I think that requires a little more thinking. We are not expecting that answer from you people. Okay.
And Anwar, if there is no history of such congenital heart disease, a patient with atrial fibrillation and a fast rate with a low pulse pressure, what will you think of? Or sorry, wide pulse pressure and low diastolic blood pressure, high volume, or a high output failure. What are the other situations which you can think of? Atrial fibrillation, wide pulse pressure, heart failure.
Is asking unrelated, not related to this patient. Am I right?
Related to this case. Sir was telling about high output failure. Thyrotoxicosis.
Yeah,
Thyrotoxic.
exactly.
Okay.
I think one of the fundamental things is to remember is that a patient suffering with heart failure with markedly elevated regular venous pressure, having a wide pulse pressure, you have to stop for a minute and think whether your diagnosis of heart failure is correct or something else is there. Okay, what is the the jugular venous pressure show? Importantly, can you just replay that video? It's a very interesting video. Now that we know he has got atrial fibrillation, so what is the wave that you are really looking at?
You are right. Go
I
ahead.
need to actually it's V wave, sir.
Mhm.
You need to palpate it with the carotid pulse. I palpated it.
Okay, you have said that it's a prominent V wave with rapid wide descent, but be
Yes.
careful. In presence of atrial fibrillation, Kussmaul sign is not that relevant because the pulse volume, the
varies.
everything goes on changing. You talk about Kussmaul sign when it's a regular hemodynamics. Regular hemodynamics means it is to be a regular rhythm. regular rhythm of the same pattern, that is either sinus or whatever it is. Kussmaul sign should not be discussed in presence of atrial fibrillation.
In a patient like this, valvular heart disease suspected, what is more obvious is rapid Y descent here. So what does that exclude?
You know the answer.
Sir, you know the answer. What does it exclude if there is a rapid Y descent? What does it exclude? What?
Tamponade.
No, you are
Tamponade.
Not tamponade, something
you know
else.
the answer. There is tricuspid
In tamponade, you cannot get a
regurgitation.
prominent V wave. There is a prominent V wave and a prominent Y descent, means it excludes one thing.
There is no.
Tricuspid.
Ah,
Yes,
tricuspid.
yes, you're right. Tricuspid,
Stenosis.
you said stenosis or?
Stenosis.
Okay. So,
They are asking again because they have given an impression that you are not confident. So your answer is right. They have given an impression that you are not confident.
okay,
Okay.
Well, good. Okay, go ahead.
go ahead.
Trachea was central, chest symmetrical, no visible sinuses or scar. Apex beat seen and felt at left 6th intercostal space, 2 cm lateral to mid-clavicular line. Right ventricular type of apex, no thrill palpable, no suprasternal or intercostal pulsations visible. There is grade 3 left parasternal heave, which is continuous with the apex. Epigastric pulsations present, type of pulsation. Palpable second heart sound. Percussion, there is cardiomegaly. Right heart border cusp, it is 3 cm lateral to right sternal border, and left heart border corresponds to apex. Your down is 3 cm below right costal
First
margin.
one, meeting level, I'll be free.
Sir,
Go ahead.
First heart sound is variable. Second heart sound loud with wide fixed split with loud P2. No third or fourth heart sound. There is a constant ejection click heard over pulmonary area. There is high pitched pansystolic murmur over left lower sternal border, which increases with inspiration. There is no mid-diastolic murmur. Other systems, there is hepatomegaly.
Can I ask you what exactly you mean by fixed split?
There is no variation between during inspiration and expiration.
So there is no variation in the split. Is that your answer?
Yes.
That wide split and fixed split. What is your definition of a wide split? Clinical definition.
Clinically by auscultation. His sir is not asking phonocardiogram.
Yeah.
Clinically by auscultation, when will you say that the split is wide? You know what is normal split?
If it is heard during inspiration and expiration.
It is wide split.
Yes.
Then what do you mean by fixed split?
There is no variation between the. There is no variation in split during inspiration and expiration.
Can you really make that out in the presence of atrial fibrillation? It's difficult.
Yeah, I think so.
Especially when the rate is fast, you can answer
Fast.
that. When the rate is controlled and the rate is slow, because when the rate is fast, we find it difficult to get tuned to the events.
Yeah.
So if a fast rate, it is not possible. Sir, when the rate is slow, say at around 60 or 70, it may be possible. It's an extremely difficult thing to assess second sound.
Yeah.
We assess second sound, write the answers once you know the diagnosis. That's what usually happens.
Yeah. That's the problem.
But you should know the phonocardiographic definition of normal wide split and variable split and fixed split. That you should know the phonocardiographic definition. You go and read. We cannot teach you everything. Okay, go ahead. Sir.
No, I just wanted to know, suppose if this is a patient of a 50-year-old man presenting with right heart failure, but with a wide pulse pressure. What is your first suspicion?
a right heart, what are the situations where you can have a heart failure and a wide pulse pressure? Normally, as I previously told, the systemic vascular resistance increases, the pulse pressure reduces in heart failure. The sympathetic activity increases, the heart rate increases, the systemic vascular resistance also increases, the pulse pressure narrows. But there are certain situations where heart failure can occur with wide pulse pressure. Which are the situations?
RSOV to RV,
Right?
then coronary cameral fistulas.
Coronary cameral fistulas, you can have continuous murmurs, but it's very rare to have a wide pulse pressure. Okay. So what do you summarize at the end of the?
Under can other diseases like anemia or beriberi or thyroid,
High output states.
high output states present with wide pulse pressure and heart failure?
Yes, sir.
Yes.
I think without murmurs, if you get atrial fibrillation, fast rate, wide heart failure with relatively less symptoms, I think thyrotoxicosis should be considered. Not in this case because the other findings are not tallying. Then natural history has diagnosed a heart disease. But if the question comes, if there is heart failure, atrial fibrillation, wide pulse pressure, if thyrotoxic has to be brought in. It may be the only thing or it may be the contributing factor. That you have to think. It may be having heart disease, thyrotoxicosis may be contributing. Okay, fine.
So based on your physical findings, what kind of hemodynamics are you expecting? You think it's a right-sided disease or a left-sided disease?
Right-sided disease.
Decree or right-sided disease with RV hypertension or RV pressure being normal?
RV hypertrophy.
RV hypertrophy, sir is asking hemodynamics. He is
Hemodynamics.
asking about the hemodynamics. RV systolic pressure, sir is asking.
Yeah.
Is it RV systolic? Somebody is.
Yeah. So this is basically a right ventricular systolic overload or a diastolic overload?
So you have the second sound. You can go through that and answer that question.
One more thing, it looks very, something like a knee-jerk reaction. In a patient with atrial fibrillation, do you ever get S4? Or written down there, no S3, no S4.
No, sir. We will not get.
Then why are you written that? It only shows that you are not considered it at all. So it is basically a right-sided disease with evidence of pulmonary hypertension as per your, what do you call, data there. So,
sir, one chat box, somebody has said that it is RV diastolic overload. We have to clarify because this patient has a loud P2 and some findings to suggest that there is pulmonary hypertension. Then we go for a hypertensive systolic hypertension is there. So that may be the reason. Your point is well taken that there is a diastolic overload also because there is right ventricular dilatation. But primarily, it is a pulmonary hypertensive situation with the right ventricular systolic hypertension and a right ventricular. So primarily, it is right ventricular systolic hypertension. Then the secondly, the patient has developed RV dilatation, tricuspid regurgitation, may have pulmonary regurgitation, producing a diastolic overload also. But sir's question was, is it a hypertensive right ventricle or not? Because he has said the second sound is loud, he is in favor of a hypertensive this thing. Regarding the wide fixed plate, don't jump to a diagnosis of ASD because any patient with severe right heart failure, I usually ask that question, what are the mechanisms of how will you explain the wide fixed plate in this case? It could be due to ASD, that's one, severe right ventricular failure, and maybe associated right bundle band block, we don't know. What is the other factor which can influence the second sound split? I would say that tricuspid regurgitation which can produce an early P2. But this TR is secondary, not primary TR. That is applicable when there is a TR. Then because just like MR producing an early P2, a TR can produce an early P2, but these are all phonocardiographic, not clinical. So, but in this case, white pixel split could be contributed by severe right ventricular failure also. That also you have to keep in mind before jumping to a diagnosis of ASD. Sir?
Yeah.
Yeah.
Then basically it is pulmonary hypertension for the physical findings at least. Cardiomegaly, parasternal heave, loud P2. So, and then there is evidence to suggest that it is a tricuspid regurgitation is present as evidenced by systolic murmur, which does increase with inspiration at the lower sternal border. So it is a hypertensive TR and with heart failure. So a cause of pulmonary hypertension in a 70-year-old man with a long history. So most likely to be.
Is it post-capillary or pre-capillary or combination? That's the approach. Okay, fine. Sir's question, you proceed.
Yeah. Going by the history, that's how we should go. Is there a history of nocturnal dyspnea? Is there any history of nocturnal cough or any evidence of left heart disease in the history? The answer is no, definitely.
No, sir. No history of orthopnea, ALD, no history of nocturnal cough.
It does not rule out, but still makes it less likely. So, what is the blood pressure you said is 130 by
2070.
Yeah, so he is not hypertensive to start. So basically, so now you have to build up the diagnosis and then tell us what is the most likely diagnosis by clinical examination.
My diagnosis: cytosolitis, levocardia, cyanotic congenital heart disease, probably ASD with left-right shunt.
Wait. What is your evidence to say left to right shunt?
What is the clinical finding needed to say that there is a left-right shunt? Auscultatory finding. That's a simple question we ask. Auscultatory finding to say that there is left-right shunt.
This is clinical examination.
Yeah.
We're not looking at X-rays and other things.
Not LVS3, because we are talking about a right heart, because chat box.
Yeah.
We're talking
Chat
about
box.
auscultatory evidence. That's a standard question. Anwar, you have to answer that.
Yes.
Yeah.
Auscultatory finding to say that ASD, there is a left-right shunt.
There is a tricuspid MDM, but there is no.
Do you expect a flow murmur to be present in the setting of a severe pulmonary hypertension?
No, sir.
No.
Generally, at what level of RV hypertension do you develop secondary TR? Generally.
If you are not sure, you can say not sure.
Okay.
What is the normal PA pressure? What is the normal PA pressure?
Systolic, mean pressure, and diastolic.
Mean pressure of 30.
No, this is how the candidates get into difficulties, not knowing the fundamentals. Just remember the rule 10, 20, 30. Okay? 30 peak systolic, it does not exceed. 10 diastolic, mean is 20. So remember the figures 10, 20, and 30. 10 is diastolic, 20 is mean, 30 is systolic. So normal pressures don't exceed that. But my question to you was, generally at what level of RV hypertension do you develop the secondary tricuspid regurgitation? If you're not sure of it, let us not waste time. Let's move on. You also said it is severe TR. What is your criteria to say severe?
CV wave in JVP.
No, wait. That in stenotic lesions, we say the valve area is the criteria, right?
Yes.
But in regurgitant lesions, what is the criteria to say it is mild regurgitation, moderate regurgitation, or severe regurgitation? It applies to all valves. But what is the parameter that you use to say it is severe TR? You understood the question?
Clinical
Yes.
or echo, sir? Your question is clinical or investigation?
No. This is written severe TR. So that is the reason why I'm asking on what basis he has thought of severe.
A length of murmur.
Okay. So basically you're telling there is tricuspid regurgitation. What is your evidence to say there is tricuspid regurgitation here in this patient?
There is pansystolic murmur or left western border. Then in GVP, the V wave is prominent.
Anything in the liver?
Suppose somebody says, why can't it be a VSD?
So you tell the findings of the tricuspid regurgitation findings apart from the murmur and a VSD, which will be the two findings. Both will have systolic murmur. So what are the findings to support? You know the answer. Support TR. One is
TR murmur increases with the respiration, inspiration.
okay, fine. Then other findings beyond auscultation.
There will be 3 in VST.
Maybe thrill, okay. But beyond auscultation, you are just concentrating on auscultation.
What is the
GVP, liver,
what is
everything
the
we can talk
no,
about.
what is the status of liver here?
Yeah.
Is it a pulsatile liver or is
That's
it
the
a
thing
non-pulsatile liver?
I have been giving a clue to him.
That is pulsatile. So TR, and there will be pulsatile hepatomegaly.
You have to say systolic pulsation. One chat box, that good answer was there. You have to say systolic pulsation of the liver, which is an indicator of severe TR. Then the
Okay.
height of the V wave, CV wave, very difficult. But if there is systolic pulsation of the liver, it is severe, because this is documented by venous Doppler also. So the question will go for venous Doppler also. That is hepatic vein Doppler. So you should be careful. When you're talking about TR, you should know about TR, you should know about the JVP, you should know about the systolic pulsation of the liver and hepatic vein. Then the question will be on hepatic vein Doppler, not only TR, others. So that's the way we build up the questions.
What is the mechanism of increase of the murmur with inspiration? Why does the murmur increase with inspiration in cases of TR? Any idea?
During inspiration, there is increase to venous return to right side.
Sir wants another answer which I have taught you.
So basically,
Sir,
what are the major determinants of regurgitation? We'll come back to the basics. One is preload. Second one is
great.
just now we were discussing about regurgitations. So second one is afterload. So during inspiration, does the PA pressure become more or less?
Air pressure become more.
More, according to you. Why should it become more?
Sorry, during inspiration, air pressure become less.
PA pressure becomes? Normally, let us say, under normal circumstances, without any heart disease, what happens to PA pressure during inspiration as compared to expiration? Does the PA pressure increase or decrease or remain the same?
Remain same.
You want a
Remain
clue?
same.
You want a clue?
Yes.
You know the RV pressures in constrict pericarditis, restricted cardiomyopathy and normal? Because we discussed constrict pericarditis, ventricular interdependence, all those things there, you should know what is the normal RV, LV systolic pressures with normal inspiration. I think you should read that. Am I right,
Yeah.
sir?
Yeah, sure. I think
You should read
there's
that.
been a very good study from the Mayo Clinic. I think you should read that. You can go on to discussing about that, but you said NIHA class 3. Anything else you want to add to that?
Pulmonary hypertension, severe TR, right heart failure, NIHA class 3, okay. Coronary heart disease based on the original diagnosis. So diagnosis of ASD is based on, what is the basis for diagnosis of ASD in this case?
Clinical findings.
Yeah.
Not the
Why did you diagnose ASD in this case? Left right shunt we have to delete because you can't diagnose. Why did you diagnose ASD in this case? That will be my first question.
The symptom status from childhood onwards.
Okay, historically we have discussed the possibility a
Yes.
congenital disease remaining minimally symptomatic, developing atrial fibrillation, cardiac failure in the later period of life. The commonest congenital disease we can present like this is ASD. But clinical finding, what is the point in favor? Any solid point in favor?
There is wide fixed
White
split
fixed split. Okay, you have to tell that white fixed split, but sir, that could be due to severe RV failure also. Okay.
Yes,
Then
yes.
you have to say, sir, I don't have any other diagnosis to explain these findings. If it is not ASD, any other, because you cannot be adamant that we have only one diagnosis. Any different diagnosis? I will ask my colleagues also. Can they entertain? Dr. Venu has been quiet for some time.
No, I've been just listening to it. I don't
Uh-huh.
have any other diagnosis. That is what I was thinking of.
No,
Oh,
my
but-
approach will be like this. Basically, this patient has pulmonary hypertension and
Yeah.
there is no post-capillary feature. So it's a pre-capillary pulmonary hypertension. The condition which I will consider will be whether it is a congenital disease like shunt, whether it's a primary lung disease, or whether it's a idiopathic PH. Idiopathic PH I may not entertain because of the long history from the age of 10 years. So I may not. Chronic lung disease, there is no history to suggest, and clinically we have said the respiratory system is normal, the oxygen saturation is normal, everything is normal. And a basic lung disease present with right heart failure, they will be severely dyspneic. And the diagnosis was made at the age of 10 years. So I think we are primarily in favor of a heart disease which has been there from the age of 10 years, congenital heart disease. This finding, the only thing which I can offer is ASD. Well, there is PH. Sir, what do you think, sir?
My question to the candidate is, which type of pulmonary hypertension it belongs to? You know the classification of pH? Type 1, type 2, type 3, type 4. So which type it belongs to? You are aware of the classification?
Which group? The WHO classification.
Yes, sir. It is in shunt.
No, which is answer is which is type
This
1, type
particular
2.
patient, which group?
Which group?
Type 1.
comes to?
Type 1.
Okay.
In type 1, where is the pathology, doctor?
It is pulmonary arterial hypertension, sir, basically.
Pulmonary. And in type 2, where is the pathology?
Type 2, it is post-capillary.
You are right.
Yeah,
It is
post-capillary. Yeah.
left heart disease causing pulmonary hypertension.
And type 3?
Type 3 is due to lung diseases.
What is the mechanism of pH in lung disease?
Sir,
Why do you-
very simple.
Decreased oxygenation of pulmonary arterial and pulmonary arterial.
You say hypoxia. You say
Also
hypoxia. is one.
constriction. Yes,
Then
also
other things
The
also.
induced vasoconstriction. And what is type 4?
Type 4 is chronic thromboembolic pulmonary hypertension.
What is the mechanism there?
It is post-capillary.
No. In pulmonary embolism. You
Chronic
think pulmonary
thromboembolic
embolism.
pulmonary hypertension.
Yes.
It
So
is
what is the
mechanical
mechanism of
plus
pulmonary-
vasoactive. You have to say mechanical obstruction plus vasoactive mechanisms.
Type 5 is?
Miscellaneous causes.
Okay.
Okay, fine. Shall we
Okay.
go to the investigation time factor? എങ്ങനെയാണ്?
Now we'll ask the candidate which investigation he would like to have. Apart from echocardiogram, whether you choose a ECG or whether you choose a X-ray.
I'll choose X-ray, sir.
For what?
I need to know the Chamberlain enlargements,
No,
No.
to sort out whether it is this pH is
pre-capillary or
that is
post-capillary.
number one, pre-capillary or post-capillary. And if it is pre-capillary, you may get some clues based on the other things.
Yes.
Okay, fine.
So what is the radiological evidence of, anyway, let's see the X-ray. We will. Yeah, okay. First question to you is there any evidence of pulmonary hypertension?
Yes, sir.
What is the evidence?
There is right pulmonary artery is prominent.
No. Radiological criteria to say pulmonary hypertension. Question is very focused. You have to give a precise answer.
Tendon vessels seen
No,
in
pulmonary hypertension, not pulmonary blood flow.
You're not sure. Okay. Next, what is the, why, is there any evidence of ASD in this X-ray?
there is RA and RV enlarged, dilated.
Mhm. Is there a LA enlargement in this X-ray?
Yes, sir.
So do you get LA enlargement in the patient with ASD?
No, sir.
So how do you explain it?
Okay. So there may be additional.
Suppose
Well,
we get LA enlargement in ASD, what is the associated lesion? What is the commonest association?
Lutenbacher syndrome. Lutenbacher syndrome.
What is the commonest association of ASD?
PAPVC.
Hey. ASD is the primary disease. ASD is a basic disease. What is the
ASD
common?
is there, which valvular heart disease is commonly associated with ASD?
MVP.
What are the associated cardiovascular anomalies that occur along with atrial septal defect, ostium secundum type?
MVP.
Yes, MVP, agreed.
MBPS. Okay.
Can mitral regurgitation occur without MVP in ASD?
In India.
Ostium primum is ASD.
Ostium primum, agreed.
Ostium primum, what is it due to?
Cleft mitral leaf.
Cleft mitral leaf. Sir,
Yes,
are they affected in India?
Yeah.
Which is the commonest cause for mitral valve disease? Etiology?
Rheumatic heart disease.
Okay.
Rheumatic is also there. So
Here,
Yes,
you are thinking it is terms of left atrial enlargement. I'm not sure whether it is spurious contributed by the negative bronchial shadow.
I am also not sure. I
I'm
also
not sure
thought so.
because I don't want the left atrial enlargement in this case. So that bronchial shadow is producing the negativity, producing a spurious because left bronchial.
I just wanted to ask the candidate, what is the radiological evidence of LA enlargement other than the shadow in shadow?
The carinal angle will be, there is lifting of the left bronchus.
Is it there?
No, sir.
You see the bifurcation angle, the carina angle.
It will be more than 70.
If the left bronchus is little elevated, left upper bronchus.
So basically, that in the good old days, what was the test done to diagnose LA enlargement? Any idea?
Radiology, sir?
Radiology.
Yes. Something to swallow? I mean, right?
Yeah. It is not very pleasant to swallow, but they are made.
Barium not meal. Barium
Barium
Barium swallow. Which view?
is
lateral view.
Pardon?
Lateral view?
No.
Totally
They are
wrong.
less likely to answer that.
I don't think they would have seen it, sir.
It is
Okay.
right angle
What about the cardiac size?
There is cardiomegaly.
There is cardiomegaly. Is there any pulmonary venous hypertension?
No, sir.
Why do you say that?
The vascularity, lower half.
What is the radiological sense of pulmonary venous hypertension?
Prominent upper lobe veins.
Upper lobe vessels. Okay.
No, prominent upper lobe vessels coupled with
Lower zone.
Coupled
lower.
with
Compared with lower.
What happens to the lower lobe vessels? They remain the same, or they enlarge, or they constrict?
not sure because
Okay. Any other
mechanism of
radiological
upper lobe
sign?
vessels. There is a problem.
Tendon vessels will be more.
Hey, we are talking about
Pulmonary
venous
venous hypertension.
upper lobe vessels. Then what else?
Then
There are 6 radiological signs. You have only one.
Curly lines.
curly lines.
Then
Fissural edema.
Idea pleural effusions.
Peribronchial coughing.
Okay.
Then pleural
perihilar haze,
yes.
fluid in the minor fissure,
Yes.
pleural effusions. So all these things, none of them are there. So you think that this X-ray is fitting with a pure isolated ostium secundum ASD according to you? Yes or no?
You say yes because your diagnosis is there. There are points in favor of that. Why do you want to take time?
Yes, sir.
No, you have said that there is right atrial enlargement, main pulmonary artery is dilated, there are large number of end-on vessels. Then your clinical diagnosis is ASD. What is the point against ASD? There is right ventricular enlargement, there is right atrial enlargement, there is pulmonary artery dilatation, large number of end-on vessels are seen. But additional point you have to say is, what is the magnitude of PAH? Is there significant PAH or not? There, look for the medial third versus the lateral third. You find there is a gross vascularity in the medial third with large number of end-on vessels, whereas if you go to the periphery, the vessels are very thin. Even though they are traceable up to the periphery, they are very thin. So there is significant precapillary vasoconstriction, precapillary PAH. That is reversible or not, it's a different phenomenon. And then you will get the questions, what about the end-on vessels? How many number normal? When will you say it is more than normal? These things you should know. Shall we go to the ECG side?
ECG followed by echo.
Something we'll give you as homework. We cannot teach you everything.
12-lead standard ECG with a, showing AF with a rate approximately 70 per minute.
Okay.
Axis is in between 90 and 120. There is QR pattern in V1.
Any comment on?
What about V5 and V6?
Deep S waves in V5.
Okay, what is the significance of that QR pattern in V1?
Severe pulmonary hypertension.
Severe pulmonary hypertension. How do you know there is pulmonary hypertension looking at the ECG?
Sir,
There's a specific terminology for that, Anwar. Severe QR pattern.
Suprasystemic.
Monophasic.
Yes.
Monophasic R wave. And there's a QR pattern. Or possibly it is an RSR pattern.
Yeah.
A small R is not visible.
In situations where there is a large right atrium, QR pattern doesn't correlate with the severity of PAH. This is classically described in ASD with a large right atrium as well as in EMF. So a QR, when there is a large right atrium, doesn't have much significance. In other situations where there is pulmonary hypertension, as sir said, monophasic RV with STT changes, or a QR in that situation where the RVs are fairly tall. In presence of a huge right atrial enlargement, which you expect if it is ASD, it doesn't have much significance.
But that QR will be very small, so they
Yeah.
go.
Here
See, if
also
it is, see
the
here,
R is not,
no, what I'm
R
not,
is
in a,
not very tall.
but you are getting a fairly good R.
Yeah, I
But
agree. I am not
EMF,
debating.
EMF and things, the R amplitude will be very low.
I am not debating that, but the point is, when there is a huge right atrium,
I agree. With
this
the right
QR
atrium,
has
yes.
limitations compared to other situations like say when you had a primary pulmonary hypertension or other severe PH or severe pulmonary stenosis, it may be useful. But when there's a huge right atrium, that extrapolation may not be always right.
Yeah,
The
but
specificity will be low.
You have to go with the other features. There is right axis deviation.
Are there the right axis
Yes.
deviations, or will it correlate with the PA pressure or the RV pressure? The QR pattern plus a right axis deviation also. And not only right axis deviation, maybe there is STT changes, there are problems. What are these ST changes due to, Anwar? Is this ischemia? Is this digitalis effect?
RV strains.
It is seen everywhere.
It's seen in the right chest leads and inferior leads, so it is predominantly right ventricular. And you have to say, sir, if there is, if I am entertaining ASD, in which case there can be RBB which can produce STT changes in right chest leads. When there is right ventricular failure, they can have changes. It could be right ventricular strain pattern, and it could be digitalis. Digitalis produces STT changes in leads over the dominant ventricle.
Yes.
Here the dominant ventricle is right ventricle. So I expect STT changes in inferior and right ventricular leads. So it could be any of these things. This is the way you have to answer. Why I'm answering is to save time. Because a pause is not sure.
Based on this ECG, you think it is an ostium primum ASD,
Yeah.
or a SVC type of ASD, or a secondum ASD?
Ostium secondum.
Sorry?
Ostium secondum is it?
He said ostium secondum, sir.
Ostium secondum because?
Why do you say Anwar it is ostium
Correct.
secondum based on this electrocardiogram?
Because
Right
ostium-
Right axis deviation.
Okay, access.
Okay.
That is the deviation of what? QRS.
Of the QRS.
Yes.
Yes.
So,
So why do you say it is atrial fibrillation to start off?
There is no P wave.
Sorry?
No P wave, sir.
Okay, wave. Second,
Irregular.
so RR intervals are irregular.
and probably you can see fine fibrillary waves in V1. I think in the initial part of the case discussion, Anwar was very confident. Now he is losing confidence. There is a problem. Whatever you say, you be confident. You are doing
Okay, let's see
fairly well.
Let's see the echo. Let's see the echo. I think it's getting late, 9:40 now. Give a running commentary, like what you hear in IPL.
There are apical for general view showing dilated RA, RV, and LA with good LV function.
LA is dilated according to you?
Yes, sir, dilated.
What is your criteria? What is your criteria by echo to say there is LA enlargement?
So we have to compare with the aorta
So,
long axis.
can you see iota here?
No, sir.
Is there any absolute numbers?
Is there any absolute number by which you can say above which
Yeah.
the LV is dilated? That's not an Indian data, but mostly the Western data.
If it is more than 4 centimeter or yes, sir.
Okay, the way you have to answer is in parasternal long axis view, then you have to say that LA volume and LA volume index. This
LA
is what
volume.
you have to know. This you have to go and read.
Okay, comment.
Okay.
Is there a mitral valve disease here or no?
No, sir. I need to see the Doppler and other images.
Yes.
Mhm.
Is
You
the
have to get
RV
multiple
function normal? Is the RV function normal?
No, sir, there is RV dysfunction. The annulus is
Be careful before answering. Okay. You have to have multiple parameters because you are not seeing fully the right ventricle. You should know which are the parameters to assess the RV function. Then only you say, sir, I want more data to assess the RV function.
I want to know
Apparently,
whether
again,
there is a ASD on this view.
So what is happening to the in-radial septum?
Is
What is the RA? Pardon? Is it in a large ASD, RA pressures and LA pressures are almost the same. So the in-radial septum will be fairly midline. Is it mid? You cannot see fully, but whatever you are seeing, is it midline or is it shifted to the LA? That's what you have to look for. But you should have better images. What is that contrast-like thing seen? You are seeing contrast-like things. Okay.
Yes.
Okay, can we go to the other views?
Yeah, yeah.
Okay. Freeze it and then your comments. Your comments. Freeze, yeah. Yeah, that's it. Yeah. Tell us. What do you make out of it? What is the hemodynamic interpretation of
There
this?
is D-shaped LV, left ventricle.
Is it in systole or diastole? In this view.
Systole.
No.
How do you know? How do you know? Wait. How do you assess?
I always told you, look at the associated thing. He will, pardon?
No, but the mitral valve is open or closed? You got an electrocardiogram.
Yeah,
At what level it is cutting?
it is
End of T wave. End of T wave means?
in diastole.
In
It is
You
after
see the
T
mitral
wave.
valve is fully open, widely open. So how can you say it is systolic? So what is the importance of this? So if it is D-shaped in diastole, what is the implication?
In diastole, if it is D-shaped, what happens? The RV is dilated and which pressure is higher?
Diastolic pressure in the RV is more than the diastolic pressure in the LV.
Okay. Okay, fine.
Oh.
Severe TR. Okay.
So what is the single most finding by which we say it is severe TR on the echo? I want one single parameter by which we say this is there, that's why it is severe TR.
You are seeing only the color imaging. So you can think, look for only two things. There is one is the color jet versus the RA area, but something more is what sir wants. What is the other thing we can easily measure or see in color Doppler? There is no calculations, but you can measure another thing.
PISA.
PISA, okay, very difficult.
This is very difficult, you know.
But still very close to that. Very close to
Vena
the
contracted.
bicuspid valve.
Orifice.
Pardon?
Regurgitant orifice.
Pardon?
Regurgitant orifice.
Vena contract.
Vena
contraction.
But
Okay,
one
so-
thing in this case, if it has been aged with pH, the TRZ should have crossed the intraretroseptal defect to the left atrium. Because severe TR, and we are saying that is significant pH, okay, it should have crossed. That is one thing which gives a suspicion that it may not be ASD.
No, you are not covering up the left atrium. Your
Okay,
window.
but where is the conductors are
Yeah.
okay, fine.
Yeah, you are not covering the left
Yeah.
atrium.
And
I
if
agree,
you, sir, if you closely look at it, the interrectal septum in this view seems to be intact.
It
Yeah,
is
yeah.
convex to the LA.
It is
And
actually
that
bulging
color
towards
towards the LA.
Yes.
bulging towards LA.
Yeah. And that color jet is smooth, it is coming smoothly as a round thing to the right atrium. Okay, fine. Go ahead.
Next view.
And the RV shows hypertrophied muscle bands also. That is something which you have to
The
mention.
moderator band is hypertrophy.
Yeah. Hypertrophied.
Yeah.
And
I'm
in-
also surprised. I was also thinking of a very definite ASD.
I also was thinking,
tricuspid valve is not coapting normally. It is not coapting valve.
yeah.
It's not a non-coapting tricuspid valve.
Annulus is quite large.
And
There is mitral regurgitation.
Yeah.
Okay, can we have other images?
Yes, go ahead.
Okay. This one will give you a lot of information.
Not very optimistic. It all depends on the way you are doing. Images may not help you much. If you
No,
are,
it is operator dependent.
it is operator and what you are looking for.
Yeah.
Okay, there is something there.
Yeah.
Okay. Again, depends on what is the view, how the transducer is directing. All those things are important. Otherwise, it will be extremely difficult.
Can we have other views?
Any other views?
And Anwar, if you are not seeing an ASD in this patient with a with this echocardiogram, what else will you go for? What else
We
will
can
you
do-
do? What else will you
We
suggest?
can go for contrast echo, sir.
No, you should
no,
look
no,
for
even
which
with
ASD.
this,
Which
even with
ASD, which
what
ASD
other
will
view,
be missed?
what other view will you?
The other view, or which is the other type of echocardiogram?
Of
You will
course.
go.
What is the other imaging methods?
Will you go for a transesophageal echocardiogram?
Yes, sir. Yes.
For what?
Which ASD is likely to be missed in transthoracic echocardiogram?
Sinus venosus ASD.
That's it. You have to go for
You got to.
T.
Thanks.
If you are not seeing an ASD in this patient with this echocardiogram, you should ask for a transesophageal echocardiogram. You should carefully look for sinus venosus ASD in the subcostal view. Adult patient, heart failure, it is extremely difficult. This patient may be very sick also.
Epigastric
What is
view
your
also
experience,
given
Dr.?
epigastric view?
No. I just wanted to ask the candidate whether he has done any transesophageal echocardiographies.
No, sir.
Yes or no?
No, sir.
Mhm. What is the frequency of the probe? Any idea? Frequency of the transesophageal probe?
No, sir.
Okay.
What is the frequency of the transthoracic probe?
5 to 5 to
Okay.
5 to 8.
Sorry? Speak out.
5 to
Loud.
8.
Mm,
5 to 8 hertz.
No. What about the adult probe? What about the pediatric probe? What about the T? I think these are things that you should know. When
No,
you do,
without that, there is no.
2 to 5 megahertz
I
for adult
think,
folks.
you will not be excused for that. Okay. Fine. I think you
Any other
learned that.
views?
You should go to the echo lab
I think-
and
next
look
time
into-
you do the echo, you should check all those things.
Yeah. Fine.
Can we have other images?
Jabber will guide you. Okay, fine. Any other images you have?
The contrast.
So what do you think after seeing this? Is it ASD or a foraminal? So you could be severe PH with foraminal right left, or an ASD. We are discussing about sinus venous ASD with bidirectional shunt or right left shunt. Obviously, there is a right left shunt. It is coming from the atrium. It is coming from the atrium. Now, we are not entertaining pulmonary AV fistula in this case, I hope, because it is appearing very early. Now, my question is it foraminal or sinus venous ASD?
Sinus venosus.
Foraminal, the anatomy you have to look into. Where is the foraminal? And it can be seen that this right to left shunt is not occurring at the typical fossa valis or foraminal area. So we are entertaining the possibility of a sinus venosus ASD. Okay, is it enough, or we have to have some other images?
Yeah, I think there's a contrast here also in this view.
Now, are you going to call this
Yeah.
primary pulmonary hypertension with PFO or?
No, this contrast is shown here, sir, clearly.
Yeah, this contrast is.
Yes. Okay, it's like
There is not much of, there is contrast spilling into the left atrium, but very infrequently.
in the other view, it was very four-chamber view, it was quite prominent. Seldom that the PFO with PH will have that much of contrast coming. And anatomical location, it was not seen. Okay, fine.
I think T would have been probably even better
Any
answer.
other? Do you have T?
No, sir. No T.
Okay.
No T.
But looking at the X-ray, looking at the natural history, disease from the age of 10 years, developing problem at 50s and 60s with atrial just after changes. X-ray showing a dilated pulmonary RPA with a large number of end-on vessels, and the central vessels are very prominent. And with this thing, I think we have to strongly consider sinus venosus ASD with a right to left shunt. Sir, and what do you think, Dr. Venu and sir?
No. See, one of the diagnostic clues to sinus, unfortunately, this patient has got atrial fibrillation. The other point in favor of sinus venosus is usually P wave abnormalities, which you specifically look for in the setting of an ASD, which is a diagnostic clue to sinus venosus. But here AF must be that particular thing.
Okay, I think. So what will you do now?
We can.
No, there is right to left shunting because I think if I am not mistaken, patient oxygen saturation was 100% breathing room air.
97%. 97%.
97%, yeah. So 97% according to you is normal or abnormal?
Normal.
Normal. So suppose if you are suspecting a severe PAH with right to left shunting, what else you can do to confirm it without doing the echo?
Exercise desaturation.
Exercise desaturation. Why does exercise exaggerate the desaturation?
You can say consumption, but what happens to the right to left shunt? What happened to the PVR? What happened to the SVR? That is, am I right, sir?
Absolutely.
You have to look at with exercise normal versus pulmonary hypertension, SVR, PVR. You have to read that.
What happens?
That you have to read. I don't think you will be able to answer that.
What is it, sir? I didn't get.
With exercise, the desaturation versus mechanism. So he has to study what is happening to the SVR and PVR normally, as well as in a pulmonary hypertension of different types with exercise. Am I right, sir? That is
Absolutely.
what
Absolutely.
yeah.
This is one of the things
This is homework for you people.
Before the era of the echocardiography, what we used to do was put a cannula into the radial artery and take the ABG at rest, ABG during exercise. So if the PO2 also falls and the saturation becomes worse, then there is evidence of that. And a right to left shunting and at baseline with exercise, of course, is you have to be careful about sending them for any surgery in those days. So basically, as an initial clue is to do a ABG at rest and ABG during exercise, because even the small amount of right to left shunt can be picked up by the ABG, which cannot be picked up by the oximetry, because there will be a fall in the PO2 even before there's a fall in saturation. So I think it's important. There are some simpler tests, but clinically, I thought it was probably a primary, as a pulmonary hypertension with TR, caused to be evaluated. But since there was history of a heart disease at the age of 10 years, somebody has advised them to undergo surgery, probably puts that ASD as the first diagnosis. ASD with PAH.
So my final question will be, because we are running short of time, I think. Am I right, Jabir?
Yes, sir.
We have
Dr.
overshot the.
What do you do for this patient? That's the most important thing. As far as the patient is concerned, what is your recommendation? Quick.
At this point of time.
What is your recommendation now? Quick. You have seen the case?
Do right heart study.
Pardon?
We can go with right heart study, and
there's no need to, but for what? Your diagnosis is ASD. By TE as well as this thing, you have diagnosed ASD. What are you going to do for this patient?
Therapy for this patient.
We can do reversibility testing for pulmonary hypertension.
Will you close the ASD or not?
No, sir. At this age.
At this age, people close the ASD. What is the data? What is the benefit of closure of ASD? Will it prevent arrhythmias? He is already in atrial fibrillation. He is in severe congestive heart failure, 70 years. We are not interested in closure of the ASD. So why do you want to? Now the role of vasodilator therapy in ASD or these types of situation, probably you may try these things. But in
Yep.
elderly people, the reactivity assessment will not be that
Waste of
difficult
time.
compared to waste of time compared to a young person with PAH, because therapeutic response and the reversibility assessment has limitations in this age group. And I think it should be left on medical management.
Anwar, and the problem, if you close this ASD, what will be the problem? Did you see that LA is enlarged? Patient has coronary artery disease, old age, he may have significant diastolic dysfunction, and if you close the ASD, he'll go into heart failure.
The other problem is that this is sinus venosus ASD. Therefore, device closure also becomes a difficult issue in this patient. Even though people have tried sinus venosus device closure, may not be a.
My approach will be, what is the benefit? What is the risk? Is there any benefit? Only if there is a benefit, we think about that. Whatever is the hemodynamics, whatever is the hemodynamics now, there is no real benefit. At 70 years with right heart failure and equilibrium, there may not be any real benefit. Was the improvement in mortality in 60 plus with ASD? That was not with this type of hemodynamics. An ASD which could be operable otherwise, left to right shunt, and you close the defect, probable reduction in the atrial arrhythmias, not fully convinced. Mortality reduction was because of prevention or reduction in frequency of pneumonias. Okay, that is in ASD with left-right shunt, not these types of cases. Okay, fine.
Sir, this patient undergone a coronary angiography some, I think, 7 years ago. He had chronic total occlusion of the RCA, chronic total occlusion of the circumflex, and the disease, the LAD also. So both lesions were not angioblastable. So we thought of medical therapy only, significant PAH at that time. So revascularization was also ruled out. He has been doing reasonably well for last 7 years of medical therapy.
As sir said there, the reason for versatility. Yeah.
No, but my point of view is, in a patient who has got such a markedly elevated venous pressure with the oxygen saturation of 97% at rest in room A, is there any shunt, significant shunt? Because if there is a shunt, there should have been desaturation more, but there is only 97. But at least if you exercise the patient, you will know. But it is only of academic interest now because of multiple comorbidities, the age factor, the arrhythmias. I don't think we are going to get anything fruitful out of our treatment. I think it should be led peacefully, and then pure medical management and what we call therapeutic lifestyle management.
See, and there is another interesting point: CT of LAD, CT of RCA circumflex, and significant LAD lesion. About 10 years ago, this person has lived like so many years.
Dr. Radish wanted to ask something.
Yeah.
Could you? I don't think he'll be able to ask it, or so he can put it in the chat box. Dr. Radish, we are here, so put it in the chat box.
Manjuna to everyone.
Naveen, can he ask it, or he has to put it in the chat box?
Sir?
Yes, go ahead.
Yes, sir.
Naveen?
Yes, sir. Yes, sir.
One student has raised his hand. He wanted to ask something.
Yes, sir. Sir, he can put it in the chat box, sir.
So far, not it. Thanks for the class, sir. Thanks for your effort of senior person.
Okay.
That's okay. It's not it in the chat box. Type message.
The chat box. I think we can call it a day. Thank you so much. Thank you, Anwar. Thank you, Sagar Rao sir, and thank you, Sudhayakumar sir, and thank you, Venu sir. And from the Koshi sir will also be joining.
It was a wonderful day because really good case. And
Really good case.
Anwar, I thought that initial half he was confident, his presentation was good. Then what happened was, just like Venki back, there was a progressive reduction in his confidence in the way he was answering. But definitely it is remaining in secondary type 1 only, which is relatively benign. It should not go to type 2. That's all. What you have to do some homework, certain areas. I have to comment. The examiners were unhappy the maximum unhappiness was on, where all of us were unhappy. Can you tell, Anwar? That is your self-assessment, the frequency of the transducers. Okay. That conveyed many things to them. So be careful.
You see, actually, most of these people are doing the procedures
Yeah.
mechanically without understanding the science part of it. That gives you a very poor opinion about the candidate. It is a general, it gives you a feeling that these people are becoming more as a trained technicians rather than as a trained cardiologists. They are doing procedures without knowing what is it made up of, or what is the frequency, what are the advantages, what are the disadvantages. All those things you should be knowing it.
And what two areas I have noted down, because this is a class for the others also. Hemod, I told you that many of you are not familiar with the normal values. And that you proved when you are asked about the question of normal PA pressure. So to all the students, my experience is not for Anwar. It is a common thing to many students. When I was interacting, they are not very familiar, confident about the normal values. So I have told the students I'm training that they should copy these normal values on the first page of the notebook.